All right, guys, well, most of us have seen a chest X-ray, and some of us rely on them more than others when making medical decisions. But regardless, the question for all of us is, what are we really looking at? Do we know how to look at a chest X-ray in a way that allows us to see what we need to see? Better yet, do you have an approach in reviewing an X-ray that will help you avoid missing something important? All right, guys, I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from being facts to understanding the why behind the clinical decisions that we all make every day. And learning the why matters because that is how we can then master the how, which is about how to take care of patients at our best. All right, guys, it is now time for my education warning. Continuing to watch this topic is meant for those medical professionals who want to truly understand. This type of information is not for everyone, so if you're still here, it means you want to understand why you do what you do in healthcare instead of what I consider superficial memorization. All right, given that, in this topic review, I'm going to demonstrate a systematic method of using two separate mnemonics for reading a chest X-ray that has worked well for me over the years and enables you to identify what we need and also help you to avoid missing the obvious. In addition, I'm going to show you how to identify common landmarks on that chest radiograph. Why does this all matter? Well, do you want to be accurate? There is evidence that the use of mnemonics like these by a resident can improve their accuracy by 15 to 25% when interpreting the chest X-ray. It's really about being systematic and reproducible. Second, it makes the reasons why we order the chest X-ray and the use of the mnemonics associated with them that I'm going to cover clinically relevant. You can't recognize the abnormal until you recognize and master what is normal. Lastly, I'm going to demonstrate how to apply these mnemonics as if we were in a real scenario like on medical rounds or in the clinic, so that you don't just sound like you know what you're doing or being a pro, but you get out of the chest X-ray what you need. Okay, the first thing that we need to do is the obvious. Are you looking at an image that is for the right patient and their ID? The next thing is considering the date and the time, especially if you're doing serial comparisons where you look at a baseline image or maybe one in the past compared to the current one. Then you really need to consider, is this an image that was acquired appropriately, the right techniques, and is worth continuing to assess and interpret? So you look at things like projection and position if they're available. And if not, these mnemonics can give us the guidance that we need to get there. So now I want to walk you through each of the steps visually real quick here, and then we're going to dive into the application of the mnemonic. So what you see here is just what I went through, is making sure you cover the basics, the patient, the ID. Again, is this the right date and time for what you ordered and you're hoping to assess compared to the others? And then giving that consideration of the position, projection, if available, as well as their overall exposure. So when we do that, that's the kind of assumed, right? Well, first mnemonic is RIPE, R-I-P-E. It stands for rotation, inspiration, penetration, and or the projection, being AP or PA views. And then the last thing is exposure or the presence of artifacts. RIPE, being the first mnemonic used, all helps you to point into the first part of the second mnemonic, which is the letter A, for adequacy of the image as well as the alignment. Because you don't want to spend time interpreting something that is poor quality, because it could lead to inaccurate interpretations or workups that are unnecessary, costly, and may expose patients to more radiation and other things. But then there's the second mnemonic. Again, here it starts with A, and it goes through the basic, almost the alphabet, right? A, B, C, D, E, F, G, H, I, I being that last part where you pull it all together, integrate, and you do the overall impression, integration, interpretation, right? But RIPE, R-I-P-E, points to and leads to that first part of adequacy and alignment. Now, one of the things that we also provide, and for those of you that are joining us on the podcast or audio version only, I know that you can't see these tables, but they're available at thisiswhy.health. For those of you that are members, you can download them. They can be good study tools. For those of you learning to do this for the first time, like for those of you that are preceptors, faculty, or attendings, those kind of things, if you find these tools helpful, you can download them and use them for your presentations and teaching these mnemonics if you find them also equally beneficial. But those tables are there for you. You have one on the RIPE mnemonic, and then we also have one on the A, B, C, D, E, F, G, H, I, alphabet soup kind of mnemonic. Again, so I'm not going to walk you through those right here. We're going to apply these in the actual assessment of a normal chest X-ray, okay? So let's dive into that. So the first letter in the first mnemonic is R for rotation. And one of the things that's important is to make sure that you don't have too much rotation. You have about a 5 or so degree error of forgiveness that still allows it to be accurate. But one of the important things when you're making this assessment is looking at what you are supposed to be seeing, right? Obviously, the radiographic imaging is projecting images based on where the X-ray beams are permeating through that tissue and then hitting the plate, depending on it's in the back or the front of the patient. Again, most portable chest X-rays are in the back. We'll look at that here in a minute. But you can see over here on the left-hand side of the screen that just looking at the bone, a normal bone anatomy, that the anterior ribs are angled slightly different than the posterior ribs. And you see that same effect in the chest X-ray itself. The other thing that you see are obviously the clavicle, the cervical spine, the thoracic spine, and a portion obviously of the lumbar spine. And so you can imagine, and I've got Bro here, which is, you know, one of my old residents, just kidding. He's still with me here. But you know, if you look at the anatomy head on, if you were to rotate and the patient would be angulated in the bed, well then those X-ray beams would be coming in at an angle, distorting shadows, especially if the plate is back here. Same thing if the plate is up in the front part of the chest and the X-ray beams were coming from the posterior side to the anterior side. So that makes it PA or you know, understanding PA versus AP projections, which we'll get to in a minute. But again, if you rotate, you see different shadows and distortions. So there's a certain degree of forgiveness, but we really do need to make sure that the patient isn't rotated, because what you're seeing and what you're trying to assess in the normal are the normal shadows and contours that are present. And one of the ways that you can do that and assess that appropriately here on the chest X-ray for position is the notation of the spinous processes here in the cervical spine. You can see the spinous processes because they're very close to the plate here, and then the trachea is in the midline. So the spinous processes align in the middle of the trachea. That's helpful. You also see the clavicles here and the clavicular heads coming down, and they're about equal distant, if you will, in that space. So the patient is not very rotated in this particular image, which makes it an appropriately positioned patient overall. Okay, what about now inspiration? And this has to do with understanding your assessment of the anterior ribs versus the posterior ribs. And again, I provide you over here on the left-hand side that bone anatomy, because you can see that the anterior ribs, just like here on Bro, the curvature of the anterior portion is different than the posterior portion. They look like they're overlapping or crisscrossing. And so you see that same effect on the chest X-ray, but an appropriate inspiratory effort is necessary in order to get a good visual field of the lungs without any distortions that will cause inaccurate interpretation. So you need to see at least what we consider 8 to 10 posterior ribs and at least 5 to 6 anterior ribs. So you can see that depending on where the location of the plate is, and if it's anterior or posterior, the plate is in the back, then the posterior ribs tend to be more detailed. if it's in the front and the X-ray beams are coming in from the posterior aspect, then the anterior portion of the ribs tend to be more detail oriented. Now again, if you don't know how to interpret the ribs on an X-ray, please refer to one of the other topic reviews where I go into a little bit more detail on identifying posterior and anterior ribs there to make that a little bit easier for you. But for simplicity purposes today, one of the things that you can see is the hard part is determining ribs 1 and 2 because of how close they really are. And again, you can see that in the image over on the left. So here's the posterior aspect of rib 1, and then here's rib 2, 3, 4, 5, 6, 7, 8. 8, 9, and then you start to see 10, and then here's 11 and 12, which end up being those kind of, they're freely floating sort of ribs. They're called the false ribs. Part of the false ribs, they're not attached to the cartilaginous portion up here that you see on the ribs. And if you kind of rotate the patient, and especially on an anatomical image like this, you can see that those ribs are just hanging out there. Bro's ribs are attached by a wire, so they're up a little bit higher, but you can see them in the back here as well, okay? And so those are important to assess, but we've got adequate actually inspiration happening because of the number of posterior ribs. Remember, 8 to 10 posterior ribs. Now, if you wanted to do the anterior ribs, again, remember they're looking like they're curving up, okay? And so again, here's rib 1, 2, 3, 4, 5, 6, 7. And so we meet the minimum of the 5 to 6 anterior ribs. So there's adequate position, there's adequate inspiration to expand those lung fields so that they can be assessed. The next thing that we need to give consideration is the projection as well as the penetration. And part of the way we understand penetration is looking at the ability to see the spine through the heart. So your cardiac silhouette resides here. Okay, there's your aortic knob, the pulmonary artery, your right atrial appendage, and the left ventricle kind of sits right here. Well, you can see in this area here the thoracic spine going through. So there's an adequate amount of penetration because you see that shadow. Again, the plate is most likely back here, and we know that when we start considering the projection for 2 reasons. So if you look at Bro and you consider the anatomy, one of the things that's back here is the scapula. And so on the chest radiograph here, you can see that the scapula comes down, goes like this. That's what that line is right there. So that's your scapula. So when they're close to the plate, they're going to show up more predominant. Also, the positioning of the patient also influences that, and I'd like to show you a little bit of what that looks like. So here on the left-hand side of the screen is a typical portable radiograph machine with where the X-ray beams come out, typically on that arm, and you can position that arm certain distance from the patient at certain angles and as such. Or you can take the patient literally to the radiology department where they have those machines already in position, and now you are able to position the patient in the position that you want with the plate where it is placed. So in this particular, on the right-hand side of the screen, you can see that the source of the radiation over here on the right-hand side is going to release those X-ray beams. We'll go through the anterior portion of the patient's chest, and the plate is on the posterior aspect of it. So this is an AP view being done on the right-hand side. Now, if you do that in someone who is obviously in the hospital, they may not be able to stand up, or you would need too much support, or they couldn't be upright completely and give you the full inspiration. So they may be in a bed. And so most commonly what we see in portable chest X-rays is that they are a AP view for that reason. They laying in the back of the bed, they put the plate behind them, and then they shoot the X-ray beams from the anterior to the posterior. And so that's why you can see some of these things show up on the radiograph. Whereas if you are in a posterior view, okay, or you do a PA, that's on the top right up here, where the X-ray beams are coming in from the patient's back to the front, but the plate now is in the anterior portion of the thoracic cage. But look at the way his shoulders are positioned on the top right. You can see that they sometimes will even have handles, and people will reach around, and as they reach around, they're grabbing, well, they're pulling those scapula out of the way, where the scapula literally move like this. So if you, let's just turn bro around here for a second, and you look at his back, you can see that the scapular lines that are in that radiographic image that I was showing you. And so one of the problems with that is, again, it's distorting part of the lung field. But if you wrap your arms around something and reach over, you move the scapula out of the way. Well, that's in part helps you to understand if it's an PA or an AP view, because while they're laying in bed, they don't do that. Or as you saw in the anterior posterior, they don't do that. And of course, in the bottom right image is a lateral. And typically where a lateral is done is when we typically are taking the patient to the radiology department, and we do what is called a PA, posterior, anterior. So the plate is up here. So the anterior ribs and the sternum are more detailed oriented. And then we do a lateral. Because the patient is obviously able to do a PA, they can do a lateral as well. And that gives us two visuals of the radiographic imaging. But we're focusing our attention right now on the traditional portable chest X-ray that is typically done in the hospital. So in this particular view, because we can see those scapula and because the spinous processes are so detailed in the posterior ribs, this looks like what is considered an AP projection. Now, sometimes the X-ray will tell you that. That's why I was saying it earlier at the beginning with the mnemonic that you want to see if that information is provided. But you should also confirm and be able to assess in real time whether that is the case or not. And then lastly, has to do with the exposure. Is the film, you see the darks and the whites appropriately? This seems very appropriate. It's not overexposed and everything is super white where you can't see anything. The patient doesn't have any clear artifacts, things distorting the image. People have body piercings. They can have also things from the hospital like wires and leads and tubes and other things that sometimes create distortions that if you're not familiar with the presence of those things, you might inaccurately interpret it as a cavitary lesion or an infiltrate or something, a nodule of some sort. So you want to look for some of those obvious artifacts that might be present and cause again distortion. Most of the time, the radiology tech will ask the patient to remove necklaces and their bras if they wear bra, those kind of things, because there's wires in them and clips and things like that. We remove piercings, or if it's possible, or obviously they make a notation on there that it is a piercing. Okay, so like I said, let's jump on to the next components of this second mnemonic, starting with letter B, which stands for bones, okay, B for bones and soft tissue. And so the bones that you want to look at in particular are the clavicle that we pointed out to, the scapula, of course, portions of the humerus. It's not obviously the complete humerus in most cases. Then we have our cervical spine up here, then our thoracic spine, and that comes through here, and then our lumbar spine down here. You want to just scan those very quickly and briefly. Some people move from the outside in or start central and move out. Either way, it doesn't matter. Look for the obvious fracture, dislocation, any obvious lesions, something that looks abnormal. As it relates to soft tissue, what many times you want to look into are these areas here in the axilla, especially if it's a trauma, because penetration of some object, stabbings, gunshot wounds, things like that, or something else, a procedure happened, you want to look for the presence of air or subcutaneous emphysema in that area. That would be potentially abnormal depending on what you're looking at. In this particular case, you can see that there's breast tissue. So this reflects does that correlate obviously to the patient that you're taking care of? But those are what those shadows and those lines mean. Sometimes that leaves also nipple marks. It's hard to discern, but this may be a nipple mark here. You typically, even though not all patients have the same nipples in alignment, but that's what you would kind of be looking for in those general vicinity or area. And so this is otherwise normal looking tissue with normal looking bones with no obvious fractures to the ribs, clavicles, scapula, humerus, the thoracic and the cervical, thoracic, and lumbar spine seems to be aligned, so there's no evidence of even obvious scoliosis or what might be potential lordosis, kyphosis kind of patterns that we see in older patients with decreased mineral density. All right, now moving on to the cardiac silhouette, C for cardiac silhouette, and the assessment of the mediastinum. And so one of the things that I like to do when assessing this is trying to think of what are you looking at in the image correlated to the patient's anatomy. We did that with the rotation assessment and the projection and the assessment of the ribs and those kind of things. It helps us to see that. So if you look at the thoracic cage, the primary organs there, you have the lungs, obviously the large blood vessels, the arteries and the veins. You have obviously the trachea, the bronchi, and then it starts to branch out, and then of course the heart. And the lungs do encapsulate a portion of the heart, and so you need to see that it's tucked inside there. You also need to recognize that there's sort of this dome shape effect underneath the inferior aspect of the ribs where the diaphragm is sitting, and so there's this curvature effect that you see also on the X-ray, and you can see that demonstrated on the left side where the curvature is going down and we form these points. Okay, if you kind of remove the lungs from there and you just look at the heart, again, the orientation of this position and this anatomical view, looking from anterior to posterior, if you will, is what you should be envisioning in your head. Obviously, it's not there, but that's the parts that you're looking for. So understanding basic anatomy correlates to why you learned it to begin with, so that when you get to these higher levels of assessment and imaging, they begin to make sense. So I tried to superimpose those there so that you could sort of visualize where are these organs in the normal anatomical space of this person's chest radiograph. And so you can see the trachea up here coming down, and then it starts to bifurcate, and you can see that that carina is roughly in this area here. You can see over here that there's the aortic knob, and it wraps around and kind of goes down posterior behind the heart and anterior to that thoracic spine. You can see the greater vessels over here branching off that are going to perfuse the sort of the lungs, and then you have obviously the bronchi and the bronchioles starting to branch out over here. These create the hilum that we typically see. And then of course we have the right atrium over here, and then we get portions of the right ventricle here, the left ventricle, and then we have the pulmonary artery and a left atrial appendage in that rough area. So obviously you have to remove that, but visually that's what you want to kind of have in your mind as you're looking at these structures. So you can see, again, the patient's trachea coming down and starting to bifurcate. And so we create this cardiac silhouette right here. There's the aortic knob. You can see it kind of wrapping down. There's the pulmonary artery notch, the left atrial appendage, and then there's the left ventricle, right? So left ventricle, this is the aorta here, and this is the right atrium here, and the right ventricle somewhere in this area here. But you need to sort of envision that because you're trying to assess what is considered the cardiothoracic ratio in the chest cavity. And you can only do that appropriately with a posterior-anterior view. Because the problem with doing it an anterior-posterior view, where the plate is on the patient's back, is that the image of the heart, because of the way the X-ray beams scatter and spread out, as it goes through the tissue and permeates and finally hits the plate, it's kind of wider than where it originates. So when the heart is closest to the plate, we see that it's more accurately sized. And again, I do a topic review on how to assess the cardiac structures in more detail, but I wanted to make sure that we at least addressed it here. But you can't really assess the cardiac thoracic ratio which we don't want to typically be greater than 0.5. And so what you're looking at is the width of the heart here compared to the thoracic width, and does it make up more than 50% of that width? Again, you can only assess that with a PA. The other things that we want to look at are the costocardiac angles. They look pretty tight, they're pretty sharp. Nothing seems to be blunting it and getting in the way right there. We also look at the width of the mediastinum here with the aortic knob, making sure that that doesn't exceed more than 6 to 8 centimeters. And if it does, then obviously that gets concerning for things like aneurysms and such. All right, now we're going to look at the diaphragm, D for diaphragm. And we have obviously two sides, two lungs. And so the right hemidiaphragm sits right over here, and the left hemidiaphragm sits over here. And you see that the right hemidiaphragm is higher than the left. And that's important to realize because anatomically, don't forget, right, your liver is sitting in this area, so it pushes up or doesn't allow the right hemidiaphragm to go down as far. So there is an unequal distribution of the right versus the left hemidiaphragm. The other thing that you want to look at here are the costophrenic angles. Again, remember it was really sharp because it kind of tucks down around the diaphragm. Those lung fields go reaching down. And that becomes important for assessing things like the presence of fluid, pulmonary edema, things like that. Looking underneath the diaphragm for a sliver of free air, which would be concerning for like a perforation. Over here, typically you see a little bit of a gastric bubble. That's where your stomach is sitting, and so sometimes it's a little bit prominent than this, what is showing on this particular view. But that's the assessment of the diaphragm in particular that you want to be looking for. The next is obviously effusions and also what is considered extrathoracic structures. So an effusion, again, you would be looking predominantly in the costophrenic angles. You want to see these very sharp, blunt, pointed differentiations at the diaphragm here. You don't want to see curves, right? So if you see that the lung fields have a curvature, a little what we call meniscus looking sign, then that usually is about 200 cc's of fluid floating around in that area that's pushing or not allowing the lung fields to completely expand. And so it's thicker in that area. The other thing that you want to consider are extrathoracic structures. So what that would be is things like tubes, if they're got an intubation, if they have a nebulizer on, they may see the tubing laying on their chest. You can see the leads. If patients have had open heart surgery, you can see the metal wires. If they have a pacemaker, you'll see the pacemaker, plus you should see the pacemaker wires that are actually implanted around certain places in the heart so that it can obviously fire. So you want to be looking for some of those things when we consider E for extrathoracic structures. All right, now moving on to the lung fields. And again, you need to have that visual in your mind of the normal anatomy. And so looking at the normal anatomy, on the right side, you can see that the right lung is divided into 3 different lobes. We have that superior lobe, then there's the middle lobe, and then there's the inferior lobe separated by these fissures. So the horizontal fissure is right here, and the right oblique is right here. And then, of course, the left side only has 2 lobes. We have the superior and inferior lobe. That's important to know, and it becomes also helpful when we do a lateral view so that we can see where this infiltrate potentially could be, if that is a concern, or a mass or something like that. Now, if you take these lungs and you now implant them into that patient's image, again, you should be able to visualize those lung fields and where those fissures would be located. And so you can see the horizontal and the inferior, and over here and these oblique fissures that separate the right side from having 3 different lobes, so you can point out where the infiltrate or the pneumonia may be located versus the left. And so if we remove those, again, you don't see those lines, except sometimes they become more prominent when we do have fluid or infiltrates present in one lobe over another. They can start to be highlighted a little bit more. But again, you have that horizontal, right? And then we have those obliques that are kind of here. They're in roughly that area. And you want to look at the lung fields. You want to see also there's presence of some vascular markings. And you can see that these little fuzzy lines are extending all the way out to the rim. There doesn't look like there's this clear, transparent effect that is consistent with like a pneumothorax and or collapsed portion of the lung. So there's these markings that extend all the way to the margins of the boundary of the lung fields here, right? So we don't see any loss of markings, whether it be vascular or tissue otherwise. So these are normal inflated lungs. Like I said, we've had appropriate inspiration. We've already determined that. There's no obvious infiltrates on here. These are normal vascular markings present on the patient. Now, what about the great vessels? So we're talking about not just the aorta, but obviously some of the branches of the aorta. You can sometimes see those. And then, of course, tracing the aorta down, knowing, again, that it curves around and goes behind the heart and in front, or starts to cross over. If you see here, it starts to cross over into that thoracic lumbar spine just underneath the diaphragm. And so, again, shadows can create distortions, and we want to look for these normal curvatures on the radiograph. So if you superimpose that on the image, again, you start to see kind of roughly where the superior vena cava is sitting, and so you see this little bit of a deviation over here because of the venous system dumping into that right side of the heart and that right atrium, okay, that's over here. And then, of course, you see the aorta coming around and coming down through here. So if you, again, you remove that, you start to see those structures. So here's a little bit of that superior vena cava over here, okay? Here's your aortic knob, and then it's kind of coming around. Here's your pulmonary artery, and then your left atrium again. So those are some of those greater vessels, and then of course you can't see the branches, but obviously off the aorta it's going up, you know, to the head and then the both extremities. And so you want to see some vascular markings from those branches coming off, and you do see some of that present here. And sometimes you'll do like one of the blood vessels will have a cross section, and it'll be blunted. It looks like a little circle there, but that's typical with the assessment of the great vessels. And then lastly are the hilum. The hilum is this sort of fuzzy area here on that radiograph, but it's demonstrated from the structures that are branching out. Remember, there's blood, arterial, venous blood coming in and out of the lungs, and then of course there's the branches of the airways themselves, and that creates this sort of tree. And you can see that the left hilum and structure sit a little bit higher than the right side. Not much, but that is true also on many images here. You can see that it's kind of in this bubble here. This is your hilum, and then up here, you see some of these branches coming down right here, okay? So that's that typical consolidation of all those vessels interacting at that level. So now we get to letter I, which is that overall integration and the final impression. So when you read the chest X-ray, you get done, you've gone through all the parts, you need to pull it all together and wrap it up with a final recommendation. That's typically what our colleagues, obviously, in radiology do. They give us the overall synopsis. The details are up above, many times in the report or the below, and where they give their impression. And so you need to be able to do the same thing, wrap it up, what does this say, and what are you going to do with it? Okay, so I would like to demonstrate that, how to use both of these mnemonics in kind of a real time without saying the mnemonic out loud. Obviously, we want to do this as if we were sitting there literally looking at it, or the team standing there around and you're all looking at the X-ray and the image, and you're the one called upon to do the interpretation. That's where we need to apply these things. So you have these mnemonics in your head, okay? And you go through them one by one in a systematic, reproducible way, and then it becomes part of just what you do. And you do it so fast that sometimes you don't even know that you're doing it. But if you develop that tool in the mnemonic early on, it works really well. All right, so there's no apparent rotation as the medial aspects of the clavicles are equidistant from the spinous processes. The trachea appears to be midline in the chest with the spinous processes centered. Overall, there appears to be a pretty good inspiratory effort. I can see at least 8 to 9 posterior ribs, counting them, 1, 2, 3, 4, 5, 6, 7, 8, 9, that are visible and showing. Next, there's adequate penetration. I can see that the spine is visible behind the heart. The projection appears to be an AP view, and the reason I say that is because there's some greater detail to those posterior ribs. I can also see the presence of the scapula, so the patient is not wrapping around. There's also normal exposure without any presence of any obvious or apparent artifacts. So it appears to be a good image, appropriate for the rest of our interpretation here. So let's now go to the bones, soft tissue, clavicles, shoulders, ribs. They all appear to be in normal alignment, no obvious or apparent fractures. There's also no apparent free air under the right hemidiaphragm or subcutaneous emphysema that I can see. There's breast tissue equal and symmetrical noted, which is consistent with our patient's gender. So given that this is an AP view, cardiothoracic ratio cannot be accurately determined. However, even if this was an AP, which it looks like it is, the heart appears to be normal size, where normally an AP would normally make it larger. So I feel pretty good that this is a normal heart size overall. It doesn't appear to be large. The right hemidiaphragm is properly elevated a little higher than the left due to the liver without, again, any free air. Costophrenic angles are sharp without any obvious effusions or edema. There's also no obvious or apparent pneumothorax. I don't see any obvious infiltrates, no obvious nodules, cavitations, abnormal vascular markings in the lung fields bilaterally. The hilum appear to be normal. Left is slightly greater than the right as expected. So this is a standard AP chest radiograph with adequate image quality. The trachea is midline with a normal appearing cardiac silhouette overall. No obvious findings concerning for pneumothorax, infiltrate, effusions, edema. So it's a normal appearing chest X-ray. Clinical correlation would be recommended. Now, our radiology colleagues many times will end with that clinical correlation recommended because they are not physically seeing and managing this patient necessarily. They're just interpreting a piece of information, an order, and an image that you have given them. And sometimes there's context with why you've ordered it, what you're looking for, what you're concerned about, why is the patient here, but sometimes they don't have all that information. And so they're telling you that if you have concern that enough to order this chest X-ray that you think that there's something abnormal going on, like you think the patient has pneumonia or pulmonary embolism or something like that, then you need to consider, is this the right image? If it's considered to be normal, that you may need to do some additional workup and evaluation. Okay, so that's why it's appropriate for our radiology colleagues to many times use that terminology, in my opinion, and I respect their position in the overall assessment of the patient. We who are actually at the bedside seeing the patient have that benefit of other information that they don't always have. So anyway, I hope you found this topic to be and review to be helpful and relevant. For those of you that want to take it just one step a little bit further, check out the deep dive associated with this particular topic that's available at thisiswhy.health and get some additional insight into why recognizing the normal is important when you start to see the abnormal. I'm going to show you some abnormal very quickly so you begin to see, wow, those shadows and those shapes and the contours actually do matter in helping you to very sometimes quickly identify a problem in the patient, especially if it's more acute. So I'm Dr. Busti. This is why we're here, guys, to invest in each other by helping us out to understand why we do what we do so you can master the how. And the how in this case is about how to systematically approach and read the chest radiograph so you get what you need out of it and you don't miss the obvious.